Hello, everyone. My name is Professor Evelyn Bischoff, previously Biskup. I'm Associate Professor at the Shanghai University of Medicine and Health Sciences and Associate Chief Physician of Internal Medicine at the Renji Hospital of the Jiaotong University School of Medicine in Shanghai, and previously attending Physician of Internal Medicine at the University Hospital of Basel in Switzerland. It is my great honor and pleasure to speak today in such a wonderful forum about a topic that is so crucial and so important. Therefore, thank you very much to all the organizers, not only for having me on board, but also, and first and above, to create this panel and publicize and democratize this extremely important topic in our medical and public health field. My topic today is sex and gender as crucial biovariables. And specifically, I would like to point out the importance of their implementation in the third level hospitals. As mentioned before, I am a medical doctor. I've previously trained in several countries, including America, and gender and sex in medicine have been a part of my focus, specifically in terms of research. For a while now. I am the co-chair of the Internal Medicine and Assessment of Gender Differences in Europe working group of the European Federation of Internal Medicine. I'm also a part of the Gender and COVID-19 working group, specifically co-leading one of their subgroups that is focusing on biology and variables, and a part of serial global networks on sex and gender. This is a short outline that we would be following in our talk. First, I would like to introduce a bit about the terminology, then to speak about sex and gender as biovariables in medical research and in medical practice, and then on how one can integrate or should integrate sex and gender dimensions in the clinical actual practice, and very importantly, in the medical teaching. Then I would also like to mention that we should stop controlling for sex and gender, a very nice publication that came out recently, and also to mention the crucial role of tertiary hospitals and how all of those aspects are actually bringing us into the era of precision medicine, where sex and gender are also playing a very important role. So let us start with the terminology. Now, we know that sex and gender are not the same. This is pretty clear for us right now. However, there is still a debate about how these terms are being used correctly. And most of the people that are dealing with this topic have seen this picture before. We have on the one side the biological sex that is mostly including the biological and physiological characteristics that mostly were defining humans as females and males, and that are mostly based on the physiognomy and on factors that are not changeable or not easily changeable. That's a very, very, very brief simplification of this definition. Now, we know in medicine and in science that this has a lot of alternations, but just at least for the beginning, sex is more focused on the biology, and gender, on the other hand, is more focused on the social attributes and the opportunities associated with being perceived and perceiving oneself as female or male, and then to encounter all the very, very complex interrelationships between those two. Now, how are we looking at sex and gender as biovariables in medical research? So medical research is where everything is starting. Based on the medical research, our clinical practice is being defined. And based on the clinical practice being defined, guidelines are being evolved and already put into trials. And then actually the patients, or we all, are benefiting or not benefiting from what the medical research found. So it is a source, it is, as to say, the beginning of the entire journey. And for many, many decades, there has been a bias in the medical research, specifically by the fact that women were not included and or females were not included into even a basic medical research. So for example, we are not only talking about a very, very known phenomenon of women not being included into medical trials, mostly because of their status of pregnancy, of their hormonal changes, not only within the lifespan from premenopause to postmenopause, but also even within a month, right? We have the circular changes. So women were very often excluded from medical trials, and this is why we have a lot of knowledge gaps in terms of diagnostics and therapeutics. But also even in basic research, we have a bias. It is something that I was very surprised to learn even back in times, that most of the studies used in mice or in animals, they were using male subjects. So they were using male animals. In labs, male mice outnumbered females 5-1. And when you can see here, males in general, in the entire studies protocols, are taking over 2/3 of all the animals. So there is a predominance of male animals in the basic studies, which definitely then also translates to the human studies. And unfortunately, this is not specific just for one field of medical research, but as you can see here in the statistics, it's in very, very many disciplines, going from general biology up onto the endocrinology and other already medical disciplines that are then being actually translated into the clinical practice. And it is a vicious circle that has to be broken, because by assuming sex as a binary variable, as we discussed before, we are putting our probands, be it animals, be it humans, into something binary, into black and white, into pink and blue, right? And into estrogen and testosterone. And then we are neglecting the entire spectrum. We are neglecting the variables, the variations, and we do not also understand where there are overlaps and interactions. So at the end of the day, whenever somebody is even stating this difference, it is being taken as something that might be very much stereotypical. And in brain studies, for example, just by using this binary variation, women were turning into something more emotional, men more aggressive. So all those things were actually just reinforcing stereotypes. So to address this stigma and to break the bias affecting science and medical practice, one would really need to implement not only a very good lens of biological sex, as you can see here, for example, always considering the actual biological sex of an animal or human, and then also make sure that all the external factors that are interplaying with the organism and are part of the gender definition are being taken under consideration and very well defined in the studies. So that at the end of the day, the bigger problem, the overarching problem will be addressed, being women being underrepresented in clinical trials, particularly in phase 1 and 2, where there is a focus on safety and where there is a focus on experimental drugs, where women very often just do not have the access to those, and then they are being approved only for males. And this also has another connection. When women are excluded from those phases in the trials or from trials in general, we do not know much about the adverse drug reactions. So we are then realizing in the real world evidence that there are higher rates of adverse drug reactions, and it may take years or decades, unfortunately, to realize that and to see that and then to take action. And we know that there are fundamental differences in women, not only in the metabolic and genetic background, but also the hormonal background. And they are all playing a role in alternating the pharmacokinetics and pharmacodynamics. How we metabolize and how we benefit from the drug is very, very much different in different organisms, but specifically between men and women, this is a big difference. Now, also there is a very inconsistent and incomplete information about specific drugs on the adverse reaction level in women that are pregnant, of course, but also lactating, and very often also in reproductive age females, where some of the drugs are just not being used out of the safety issue. So these are all aspects that have to be addressed. And luckily, right now, there are wonderful institutes that are giving credible guidances and recommendations of how specific sex and gender research methods can be applied to qualitative and quantitative and mixed studies, so that the protocol can a priori be inclusive of those variables and then yield very, very credible outcomes that can be used and can be further evaluated also on the sex and gender aspect. So for example, Canadian Institute of Health Research is doing that. Also the NIH is encouraging to implement sex and gender as variables. And on their websites, you can find protocols on how to implement those variables into the medical research, so that we can actually apply sex and gender as variables in the medical practice. And this is the next point that I would like to talk about. So we know that it is most crucial to consider everybody as an individual while treating a patient. Now, we know that we do not usually have enough time to do that for each patient, but one of the most important things would be always to consider sex and gender as variables. Just as we do it, we partially cover it already in our anamnesis. So we are usually assuming that a patient is a man or female. It is important to enforce the fact that there are intersex or individuals that have to be maybe more explored, and this should be a fact that should be known to a doctor. But then also we know that all the other factors that we should be asking about, so the social life, the past medical history, the disease history, the family history, and then hopefully also more and more the specific individual data of the patient will help us to understand also the gender aspect. So meanwhile, we are still struggling very much to really implement the second part, the gender part, into the medical practice. It is now starting to have an impact. Usually what we are looking at in our patients are the cis or iso sex individuals. So we are actually we are looking at the cisgender. What it means is we are referring to a patient that is actually associating him or herself with the sex, biological sex that he or she was born with, right? So this is mostly what we are assuming, but again, it's an assumption, and we have to move from the nature of assuming into the nature of asking, inquiring, and then treating the patient accordingly and specifically. Now, why is it important that we do integrate this sex and gender lens into our medical practice? Now, unfortunately, I do not have enough time to show you the abundance of evidence that we have already on the differences in adverse reactions and the differences in diagnostic approaches for various diseases in women, the differences in different symptoms of emergencies in women and men. For example, the heart attack or the stroke are presenting in women sometimes fully differently than in men. But what I would like to perhaps underline in this point is really the point of pharmacologic use of drugs. So for example, between 1997 and 2000, 8 of 10 drugs were withdrawn from the market. Why? Because they have shown adverse reaction in women. And women actually, only in the US, in the past decade, they suffered over 2 million adverse reactions. Meanwhile, the men suffered about just half of them. So this is again rooted actually, as we said, in the medical research problem, where mostly men are being included into the clinical trials. Now, we know that adverse reactions are including various hormone-related bases, and most of those are also related to the brain health, but not only. So very interestingly, also the statins are an extremely bright and broadly used medication, has been shown with more adverse reaction in women than in men. So we are very much looking at a new era where we are moving from the assumption that if a dose for a man is good, then the same dose for a female would be appropriate. And we are moving also from the fact, or from the assumption, that if a generic formulation of a compound is good for a male, then it would also be good for women, right? So we are now going really into a more individualized base. And for me personally, implementing sex and gender in medical practice can only bring benefits, because it will not only increase the efficacy and the safety for the patient, but it will also cut the costs, as we have seen for females. Not only they usually do not need the same amount of dosage as men, but also, of course, the adverse reactions and complications are very, very costly. Of course, we would increase the equality and equity in public health and enhance the precision medicine, and also be more empathic to patients that are indeed not only binary, right? So showing more empathy into or onto the gender level and identities. And of course, it is enforcing the science. So what I am mostly personally driven about in the debate of sex and gender is indeed the scientific field in terms of biology and biovariability. Now, how can we implement those dimensions into the clinical practice and medical teaching? There are ways now to do it. And luckily, as we know, we should never be tired of learning and to teach others. And there are wonderful groups who are underlining that female and male diseases are differing, and they are differing in all the disciplines, as to say. And there is a wonderful publication that came out just last year on sex and gender and modifiers of health, disease, and medicine, where the authors have very nicely summarized on how sex and gender are differing and how many factors are influencing it, not only in terms of the intrinsic, but also on the external factors, and how all that I have been trying to show also in this presentation is coming together. Medical research as a backbone is extremely important, because it is giving us, to say, the root for the clinical practice, where the norms and the guidelines are being created, and where there's the real translation from the research to the patient. And last but not least, what is extremely important is the medical education. So the medical education right now is unfortunately not including sex and gender in such an abundance as it should be. And there are now ways to enforce it and to improve it. Now, what is very important for especially the tertiary hospitals, those university hospitals, hospitals where there is teaching, hospitals where there is research, and hospitals where there are patients that are actually directly benefiting from it. It's very much recommended that sex and gender will be included as primary variables in all the studies that are being conducted in those institutes. And sex and gender has to be implemented and incorporated into the education, not only of students, preferably also already medical students, but also healthcare professionals. So the continuing medical education, the ongoing education is something extremely crucial. And there are wonderful sources right now of sex and gender institutes where there are not only information for professionals, but also for healthcare professionals or beginning medical students that should be familiarized with the topic, and the curricula are developed in a way so that the the person can really establish a good and stable basis. And then later on, being a physician or being a researcher or both, being an academic physician, can implement it and actually drive the process. And last but not least, there are also great groups that are dealing with the topic. So one of those or several of those I have been listing in the beginning of my presentation. And just one word on the COVID. I believe in all the misery that has happened, COVID-19 did one thing that actually allowed the arena of sex and gender in medicine to progress. And it is the fact that COVID-19 really unveiled and showed that sex and gender matter. And there are wonderful publications out there coming out pretty much on a weekly basis that are showing how the biological sex and more also the gender component are playing a role, not only in the infectiology, not only in the mortality and severity of the infection, but now also more and more, of course, on the response and the actual efficacy of the vaccines. So this said, it's very important for me also to mention one point. We should definitely stop controlling for sex and gender in global health research. What it means usually in the studies when we are controlling for something, it means we are trying to avoid or to eliminate those variables because they are being a bias or being a confounder, being something disturbing. Now, usually in the terminology of research, people were usually saying this and that was controlled for sex and or for gender. Now, meanwhile, it should be just the opposite and exactly the contrast of the paradigm. So instead of controlling for sex and gender, one should rather include a priori those variables and to consider them as variables and to really manifest them into the study protocol in order to account for them. Because as we know, and this is one of the best studies done so far, in my opinion, that was looking at the heart attacks in males and females and was specifically looking at sex and gender. And as you can see here, when looked at sex as a purely binary variable, the myocardial infection rate was pretty much the same, the recurrence of the myocardial infection. However, when the authors looked at really the gender aspect, so the masculinity and the femininity of the patients, they show that the feminine characteristics of the patients were associated with a much higher level of recurrence. And I believe that only in this way we can progress, by talking and by implementing sex and gender in tertiary hospitals. Why? Because, as I mentioned, those hospitals are actually covering all the three crucial fields where sex and gender has to be, they have to become factors. It means medical research, medical clinical practice, and medical teaching. So when all of those will be implemented, then we will have a fundamental step towards precision medicine. And I believe this is where we are going. We are going from the reactive to the proactive medicine, where we are trying to move from treating the disease, but rather be at the top front gear of the diagnostics and therapeutics, and to look at everybody more and more, not as a group, but more as an individual. So we are now looking at something, and we have tools for that. We have machine learning, we have deep learning. We are now able to collect a huge amount of data and then to process it and then develop ways and trajectories for therapeutics and diagnostics that will be really directed to a specific patient group, hopefully very soon also to a specific patient. And this is the moment where we can and should include sex and gender as factors in these data sets. And this appeals not only to science and scientists, but more so to clinicians that are collecting the data just per se, and to any of the regulatories and public health authorities that are also looking at big data and should implement sex and gender as very important factors in their studies. I'm at this point very thankful and happy once again to be a part of this event. For any questions, please feel free to contact me. And at this point, I would like to thank you very much and congratulate you again to this wonderful event.